This is a continuation of our MMA webinar series, which has been going all year. And we're delighted to have so many people with us and following our webinars throughout this year. We've had some wonderful feedback, and I'm sure you'll find that Rachel is incredibly knowledgeable in her field, and we're very lucky to have her on our advisory panel and here today. So, what can I tell you? Ilan, we're going to start with just some introductory slides. We'd also like to acknowledge the owners of the lands where all of us stand, their elders, past and present and emerging. And we acknowledge the medicine keepers, the people of tribes, ancient tribes from across the world who've kept these medicines available and alive to us through the ages and have held the light in spite of some of the challenges. So we're very grateful to those medicine keepers as well. So Ilan, we'll just show the quick introductory slides, please. So yes, this webinar is called Psychedelic-Assisted Psychotherapy and Post-Traumatic Stress Disorder, which is Rachel's speciality. We'll move to the next slide. Mind Medicine Australia doesn't facilitate the use of psychedelic or plant medicines. We need to say that clearly to you. Our focus is on the medical use of these substances. We are recording this webinar and we invite you to share it with others. Go back and have a look. And of course, there's a lot of people who are registered who will be accessing the recording. We've had a lot of views of our recordings of webinars throughout the year. Next slide, thank you. So we have this massive and accelerating mental health crisis in Australia, of course, throughout the world, but Australia is particularly bad. We're only second worst in the world, only ahead of Iceland, which is a really terrible indictment. Before COVID and the bushfire crises, we had 1 in 5 Australian adults with a mental illness, 1 in 8 on antidepressants, including 1 in 4 older Australians and children as young as 5 being prescribed antidepressants. It's estimated that 1 in 2 of us will experience a mental health illness in our lifetimes. And at the moment, we're seeing statistics such as a 33% increase in self-harm of young people. We're seeing 4 out of 5 Australians saying that their mental health has deteriorated through this crisis. And we're seeing a real increase in trauma, particularly in young people who haven't been able to attend school and go about normal routine activities. We'll move on to the next slide. So unfortunately, the treatment outcomes remain inadequate. Only a very small percentage of sufferers experience remission from either depression or post-traumatic stress disorder with current existing treatments, and the side effects are significant. So more of the same is not going to solve the problem. Next slide, thank you. So Mind Medicine Australia is a registered charity that has been set up by my husband, Peter Hunt, and I to expand the treatment options available to medical practitioners and their patients through establishing safe and effective psychedelic-assisted treatments to cure a range of mental illnesses. Our primary focus is on psilocybin and MDMA at the moment. However, we're also interested in other psychedelics, including ketamine, ibogaine, ayahuasca, and DMT. For us, success will look like these therapies are an integrated part of our mental health system. So if you go to the doctor with some type of mental ailment, anxiety, depression, some stress or trauma, that you will be given this as an option of treatment with full disclosure on the risks and benefits of all treatments being offered to you. That the medicines will continue to achieve very high remission rates, thus improving our mental health statistics. And our goal, of course, is that these medicines are accessible and affordable to all Australians in need. Next slide. So we're focused on psilocybin for depression and potentially OCD and addiction, and also MDMA for PTSD and the treatment of addiction. The remarkable thing about these medicines is they only require 2 to 3 dose sessions in contrast to conventional treatments. So, you know, this is not like a life sentence of some type of medication or psychotherapy. This is a real potential cure, which is why the medicines are called curative and not palliative. So they're not simply managing a condition or even potentially making it worse. The other really important thing about these medicines is that they're considered extremely safe in medically controlled environments and non-addictive. Both have been granted breakthrough therapy status by the FDA in the US to fast track the approval process to prescription medicine. And this type of approval and breakthrough therapy designation is only granted to medicines that are considered vastly superior to existing treatments available. Next slide. One of my favorite slides here, and this is really what's happening, particularly with psilocybin for depression, and also psilocybin is also being used to treat PTSD in some cases. But you can see there that wonderful image, an fMRI scan representation of a patient with depression, very rigid and repetitive thought loops, not a lot of neural connections in the right-hand circle. And then on the left-hand circle, we see this intervention with the psilocybin leading to this massive neurogenesis, reconnection of old neural pathways, creation of new neural pathways, leading to increased neural plasticity and giving patients a chance to break out of what's called the default mode network, which keeps us stuck in repetitive styles of thinking. These medicines and treatments allow us to break out of these repetitive patterns to form new coping networks and coping skills, and empowering patients to be responsible for their own healing rather than daily use of some types of medication or other type of treatment. Next slide, thank you. So this is the final slide before I introduce Rachel. So our goal is to build the ecosystem for these medicines in Australia and the Asia Pacific region. We do that through 4 key strategies. One of them is awareness and knowledge building, so education and events like today's event. We have some screenings coming up as well, really interesting screening coming up again. Various information and education events in partnership with hospital and university and other groups and government groups. A major international summit in November 2021. And Rachel, we should definitely talk to you about coming to Melbourne for that. And we have some of the leading researchers and psychiatrists in the world attending that in November 2021. We also have state and regional chapters. So we have over 25 chapters throughout Australia and New Zealand to help educate communities at a local level about these medicines. We've also set up the very first certificate in psychedelic-assisted therapies for the Southern Hemisphere, and that will commence the first intake in January, the second one in July 2021, and have brought over Renee Harvey, a wonderful clinical psychologist from the UK who worked on the psilocybin trials at Imperial College, to help design that program. Our first intake is full, but there is a wait list, and then we have intakes 2, 3, and 4 online now as well, I think. We also are developing an Asia Pacific Centre for Emerging Mental Health Therapies for applied research and development, looking at supply chains, agribusiness, education, and then of course, finally, we're looking at preferred legal and ethical frameworks for these medicines. So many of you will realise and remember that we've recently applied for the rescheduling of MDMA and psilocybin, and fingers and toes crossed for those reschedulings to go ahead, taking the medicines from prohibited substance into category 8, which is a controlled medicine. And these medicines at the very least should be controlled medicines. As well, we have a psych support services program, and we're looking at rollout strategies for clinics. So with that, we will go to open the screen for everyone. We will be responding to questions on the chat. So if you do have questions for Rachel, please put them into the chat, and we will get through as many of those questions as we can as well. Rachel is an incredibly accomplished person. We're very lucky to have her as part of our advisory panel, as I mentioned. And she doesn't want me to say too much about it because I think she's very modest. Is that right, Rachel?
Thank you.
Yeah, but I am going to say a little bit about you, Rachel. Um, so Dr. Rachel Yehuda, PhD, is a professor of psychiatry and neuroscience at the Icahn School of Medicine at Mount Sinai and director of Mental Health Patient Care Center at the James J. Peters Bronx Veterans Affairs Hospital in New York City. She's been published prolifically, and her research on PTSD has included both human populations, animal models, neuroimaging, genomics, a whole range of work, particularly in intergenerational trauma, which we're definitely going to cover today. And Rachel, you just mentioned that you've just set up a new center for psychedelic-assisted therapies and their relevance to treating trauma. Is that correct?
Yeah, we're going to be launching it very, very soon. It's
Yes.
it's a center to do research.
Right. So exciting.
Yes.
Congratulations.
Thank you.
And you're running that center as well, are you?
For now, yes.
So you've got a few different jobs there.
Yeah.
So what I thought would be really good is if you could just let everyone know really what first brought you into an interest in the psychedelic assisted therapies before I ask you some other questions.
Well, my interest in psychedelic psychotherapy is very recent. I had known about the trials that MAPS was conducting on MDMA-assisted psychotherapy for a few years, but it's very common in the field of PTSD for people to make very great claims about different methods of psychotherapy. And so I had heard about psychedelic assisted psychotherapy, but I didn't really understand what it was. And then a few years ago, I had the occasion to meet Rick Doblin, who invited me to a training sponsored by MAPS to learn more about psychedelic assisted psychotherapy. And I went in with an open mind and went out with a tremendous optimism that this provides a really interesting way to deal with the problem of PTSD, which has been a very difficult problem for people to deal with. So the more I began to talk to people who have worked either as therapists or patients, and the more I read about it, the more the idea really had some merit. But what I felt was that it is important, since we're just at the beginning of our understanding of psychedelic assisted psychotherapy, to do really rigorous research so that we can have the information that we need to be able to understand for whom these therapies are warranted and how they can be implemented in the safest way possible.
And you're doing some of that research in your new center?
We haven't started doing any of that research yet. We're just starting up in the United States. It is quite a process to establish a research infrastructure for a Schedule I compound, which is what MDMA is. And so you have to get a lot of approvals, and we are undergoing that process right now. So it is our hope that within the next few months, we will begin to do at least the first trial, which will be MDMA-assisted psychotherapy in PTSD.
Fantastic.
So we're excited about that. Yeah.
And how many patients are you expecting to have in that one?
Well, we have written an ambitious protocol, and we would like to test 60 patients.
Fantastic.
Yes, and you mentioned in your introduction that MDMA-assisted psychotherapy consists generally of a few experimental sessions. And one of the things we're going to be testing is the relative benefits of having 3 experimental sessions versus 2 sessions. But, I did want to make the point when you were discussing the therapy that the experimental sessions are only a part of what happens with MDMA
Absolutely.
therapy. And it's just really important for people to know that these therapies are really being done to assist a process of integration that then becomes easier to do. And that there are just as many hours in preparation and integration as there are really for the psychotherapy sometimes, for the experimental sessions. And that's important because there are no quick fixes. And even something like a course of MDMA assisted psychotherapy, we're looking at a 3-month procedure. So I think that's a really important thing to emphasize. I think sometimes people get the idea, oh, let's just do psychedelics and we'll be all better. And I think that that's something that has to be corrected, that there's still a lot of work, a lot of therapy work that are done to really talk about what happened while somebody was in an altered state of consciousness. What were the insights that they gathered, things like that.
Yeah, I think that's incredibly important, and certainly we do emphasize the fact of the importance of the integration process.
Yeah.
It's absolutely fundamental. I guess the really great thing is that these therapies, I mean, 3 months, if people can get better, and we look at some of those results, say from the phase 2 trials that MAPS has had with 105 patients, 52% went into remission after the 3 treatments with integration sessions. And at the end of 12 months, 67% were in remission, of course, which is just outstanding. And of course, if there's some way that we can help people to get better more quickly, won't that be a wonderful gift that we can give people?
Right. So, I mean, we have a new therapeutic modality to study, and that's what we have to do.
Yeah.
We have to really test it in very vulnerable populations, and then see if we can replicate those great results in other settings.
No, wonderful. So I wanted to go back to some of your really huge area of interest. One of the reasons why I originally reached out to you for Mind Medicine Australia was because of your work around intergenerational trauma. And I wondered if you might just share very briefly, because I've got quite a lot of questions, so we might go through them quite quickly so that we allow the audience some question time as well. But how does trauma and resilience cross generations? Like, do we inherit memories and responses of a parental trauma, like fear and depression and anxiety and other mental health issues? I mean, obviously, I have been working with these medicines for a few years now, and I am the daughter and granddaughter of Holocaust survivors, and this was what really actually probably steered me in the direction of these medicines to begin with. So how does it happen that I'm in a psychedelic therapy session and I start to see images of the Holocaust, for example? What's going on?
Yeah, you've asked a lot of questions in that
Sorry.
question. No,
Yeah.
no, good. And let's put aside for a minute the issue of why a child or a grandchild of a Holocaust survivor might connect with a memory of the Holocaust during a psychedelic experience, and just talk about the phenomenon of intergenerational transmission. Because you asked me a good question, whether we inherit memories of a parental trauma, or whether we inherit a response to trauma, like a certain fear of the environment, or whether we inherit mental health symptoms or anything like that. And does inheriting those things prevent us from responding to the environment or something like that? When a scientist like me tries to address that issue, I'm not going to ask questions in that way of, do you inherit a memory? Because that would be very hard to study, because you might have a memory of the Holocaust, but it might not have been something that actually happened. But what you might have are specific behaviors that look very similar to behaviors that you would see in people who are exposed to trauma, or you might have changes in blood chemistry or epigenetic marks that are similar to those that can be observed in trauma survivors. And the question would be, how did those things get there? So definitely there is a phenomena that there are effects of trauma in the next generation. I would say right from the outset that not all of those effects are bad. They're just effects. The fact of trauma exposure in a parent or grandparent will leave some sort of imprint. Doesn't necessarily have to be negative. One could just as easily say that if you had a parent or a grandparent exposed to trauma, you might have a keener threat detector that allows you to better visualize and respond to danger. You might have better coping strategies, like the ones that kept your ancestors alive, or you might have a greater sense of righteous indignation or humanity and empathy. I like how you started off the podcast. I know it's very common in Australia to honor the owners of the land, but they're saying and there's really feeling it. And people who have had ancestors that have suffered sometimes really do have this greater sense of humanity and empathy and greater inclination towards social justice. So the idea here is that we're affected. And we can go into the science if you want about the DNA and how one can transmit that thing, but that's not the question you asked me. So now I'll go to the question you asked me about why you might connect with a memory during a psychedelic experience. When you take a psychedelic, you are altering you're experiencing an alteration in your normal state of consciousness, and also an enhanced acuity of the senses. And one of the things that happens is that you do feel more connected to aspects of yourself and your world that you're just not generally as connected to. So it stands to reason that if one of those things that is in your consciousness has to do with your ancestral experiences, particularly something like the Holocaust, which is so defining, it makes sense that when you're in an altered state of consciousness, you can access that far more readily. And a lot of people I have heard really do think about ancestral traumatic experiences like the Holocaust in an altered state of consciousness because it's so much more readily available to them in a way that it isn't in one's normal state of consciousness. So it's just a way of expanding one's connection, including with one's histories. People talk about being more connected to the earth, being more connected to people, to your therapists, to one another, right? So connection to history is just another way of connection more generally. So that makes sense to me.
It is fascinating. You've answered that question, so that was good. So there are benefits. That's good to know. I know I've certainly experienced some of the benefits.
Well, it's how you use it. You know, you get
Yeah,
it's
like
with
anything.
any gift that you inherit. It's about the context in which you receive the gift, how much, and how you put the gift to use. The gift itself is not necessarily positive or negative. It's the environment that and your context that really determines how useful it is, really.
No, absolutely. And what are some of the current approaches that are used in the field for treating PTSD? Like, where do psychedelics fit in? Like, do you see them replacing other therapies or sitting side by side with them?
Well, look, let's just be very clear. Psychedelics at this time are not legal. They're not legally approved treatments. So if people are being treated with psychedelics for their PTSD, I would imagine that it would either be in the context of an approved clinical trial or in the context of being underground, in which case it's not regulated in any way. So it's hard to know, it's hard for me to comment on that. So the treatments that are being used for PTSD right now are generally cognitive behavioral psychotherapy. That's considered the gold standard. And medication with antidepressants. Those are the things that the treatment guidelines recommend.
Mhm.
And you said it, it's true. Those therapies offer some symptom relief, but they're not game changers. They don't really bring about the profound level of sustained change that patients with PTSD really need in order to kind of go to a different place with their PTSD, so that they really have a very new way of looking at their experiences and what has happened to them. They don't get you far enough. Now, sometimes they can work in the case of an uncomplicated trauma where there's not a lot of shame involved in what happened. It's not complex, it's not chronic, it doesn't cause confusion, or it's not morally ambiguous. It's like a very straightforward event. But most of the traumas that happen to us are more complicated. And can be confusing. I mean, combat trauma is a trauma where somebody is attacked, but also attacks, right? It's a trauma where a lot of death and destruction happen, but many combat veterans are involved in really helping people and doing a lot of good. So a lot of experiences have many, many sides to them. Sexual trauma can be like that too. People who experience sexual trauma as children sometimes get an extra dose of love and caring with that from the perpetrator. It's very confusing. A lot of women are in abusive relationships because sometimes with all the abuse, there are moments where they can feel special. After a while, not enough, and they have to get out. But traumas are complicated, and PTSD is complicated because in addition to the core symptoms of PTSD, there are a lot of other psychological manifestations, not just PTSD. People can be physically injured, they could have a traumatic brain injury, they can express suicidal ideation, they can have substance abuse. So again, the cognitive behavioral approaches really don't solve the problem to the extent that people need to get on with their life. And in fact, a clinically meaningful response to those kinds of therapies is considered like a 12-point decline on the clinician administered PTSD scale, which isn't very much for someone who might start out with a 70 or something like that. So they may take I think, it's hard for me because on the one hand, I think having therapy is better than not having therapy, and you don't want to discourage people from seeking care. But I think there's something about having a directive approach where you're asking somebody to talk about a specific trauma and really not letting them explore their own lives and how a negative experience or a traumatic experience may fit into the context of a much greater life, including their ancestors, including a lot of contextual issues. And the kind of exploration that is enabled by a psychedelic, and again, you don't need the psychedelic to do it, it just enables it, is to really kind of let your body's own inner healer take you to places that you might not know are relevant in the context of an adult trauma. Like, why did this thing affect me so much? It might connect you with something from your early childhood, some sort of loss or some sort of clue. And cognitive behavioral approaches don't really do it that much. They're very focused on what can I do in the here and now about this particular trauma. The idea is to habituate, to desensitize, as if you're trying to extinguish a fear behavior. And it's almost as if the problem starts from the trauma and it's going to end by just talking about the trauma. And there's a whole before and a whole after. And sometimes healing just involves engaging with a much greater set of personal experiences and attitudes, and also feeling a changed state, feeling a sense of being connected or an enhanced sense of empathy. People with PTSD have a lot of shame, and when they start talking about a trauma, sometimes it's very hard for them. It's very distressing. It's very re-traumatizing. They have an internal narrator that is full of self-recrimination. And so without changing your state, it's hard to do the work that a lot of cognitive behavioral therapists want you to do, and probably can be done if it weren't so re-traumatizing. So the idea is really how to facilitate a process that is conducive to taking a different look at what happened to you. And that's where the psychedelic can be useful. It may facilitate that process, but you still have to do the work. It's not a magic pill. And it's just very important that people understand that they're going to still have to confront a lot of things. It's just not going to be as distressing for them.
Well, and that's wonderful, isn't it? You know, if you can actually go back and you can talk about the trauma in a way that you feel a sense of, you know, in some cases, love and acceptance, that's a wonderful opportunity window for healing to occur. And it's interesting to see how those remissions seem to persist quite a lot. You might have seen that, I'm sure you would have seen that documentary Trip of Compassion. And to see the persisting nature of those remissions, I mean, obviously the patients did a lot of work themselves and with their therapists.
It's very promising. And now the goal is to really provide a lot of education to people so that we can get this into the mainstream, that we can study it, that we can get the information that we need in order to be able to get to the approval and the place where people are not so afraid to try it. I mean, when you talk to people who are involved in psychedelics, they're all gung-ho, like let's get this out there. But really, there's a whole mental health community and a whole medical community that is not that familiar with psychedelics, and they're a little scared of them. And so what's really important is to be able to understand where some of those fears come from, where some of the reluctance comes from, and to really do the kind of scientific work that will allay the fears. So for example, before MDMA is a good example, before psychedelics were scheduled or classified as drugs that cause all risk and no medical benefits in the United States, they began scheduling these drugs in the 1960s and through the 70s. Before that, there was an interest in the government funding research into the therapeutic effects of these medicines as aiding in psychotherapy. But in the 60s, with the counterculture and the anti-Vietnam War protests, these drugs began to be made illegal, and research into the therapeutic effects of psychedelics stopped. But the research into the potential negative consequences of psychedelics when taken inappropriately really strengthened. And so as a result, you have several decades of scientific research on psychedelics that just shows the downside of when these drugs are not taken therapeutically, or when taken in toxic doses, or when taken just not as they should be taken. And some of the results of those studies, you know, have presented information that is scary and needs to now be changed by doing the kind of scientific work that that provides the right information. The positive changes that can occur from taking psychedelics in a way that results in positive clinical outcomes. So essentially, if we can apply the studies of the biology of resilience to how psychedelics work, that may do a lot to help the medical community really understand the therapeutic benefits and not just be swayed by this one-way narrative that we have in the field about negative effects of psychedelics. I think that's why I was so interested in doing this kind of research, because it's time for the pendulum to really swing, and we have to replace the science of what can go wrong when these drugs are used inappropriately with what actually goes right when we use therapeutically. That's a really important thing for us to do.
Absolutely. And of course, the really positive thing here is that, in some, I think 120 current and recent trials, there have been no adverse events within any of these trials, which is cause for, great comfort, because, we're not seeing people having any extreme responses or any type of, allergic or other non-safe reaction, or people escaping the room, or, any of that sort of thing. So people are feeling very, very much more comfortable.
Yeah, one of the things that was really important in our the training, in the MAPS training, was to watch the videos of people becoming quite distressed when they were kind of coming close to the traumatic memory, and the instruction of how to help people hold their process and not get very upset when the patient is reliving a distressing memory was really very important, because I think that's part of the healing process, to make room for some of the really for the distress that you can feel when you're reminded of something distressing, and not really try to help the patient avoid or push it away. So yeah, I agree with you. I think that going through this kind of process can be very cathartic and very, very healing.
There's just a question actually come up on the chat, which I will address before I ask my next question to you. If psychedelics dislodge both negative and positive memories, what happens if deeply buried negative memories that had diminished come to the fore? What would be the risk, and how those negative effects managed in the treatment?
Yeah, it's such a really good question. I mean, in general, let's keep psychedelics out of it. This can happen just in regular therapy. I had a Holocaust survivor came to our Holocaust clinic for therapy, and she said to me, "Dr. Yehuda, I want to come to your clinic. I was a child during the Holocaust, and I will only come to the clinic if you can guarantee me that you'll help me remember my good memories of my childhood. I don't want to have any, I don't want to remember anything that's negative." Right. She had basically repressed everything. She couldn't remember very much about the Holocaust at all. And, it doesn't work that way. A lot of us are very afraid of what might be, I guess, in the sub-basement, buried deep underneath. And what a good psychotherapy does, and what a good psychedelic experience can do, is help you confront what's there and make room for it, and not feel that you have to run away for it. You can come to accept something negative as part of you without rejecting it or judging it. And in a way, that is a very big gift that you give to yourself. In successful trauma therapy, with or without psychedelics, it usually involves having a very different perception about what happened to you. The same thing happened to you. You don't change your history. You don't change the fact that something happened, but you change the way you look at it. So that the point isn't to be afraid of a negative memory. You want to bring those memories up. You want to understand what you were afraid of. And then you want to have a very different take to yourself about what those memories represent to you. Again, we're all afraid of those ghosts. We're all afraid that we're going to learn something that will even make us feel worse about ourselves than we already do, or make us or confirm some hidden fear that we're, you know, not good. You know, as one of our patients in group once said, the "you're no good, you're no good, you're no good, baby, you're no good" feeling. You know, it's there, and I guess that's part of the pathology, that you've taken an event and really internalized this around your own badness. But if you could look at it from a different perspective, from an altered state of consciousness, or just from a different perspective, even without psychedelics, you might come to view the event very, very differently. And that's really at the heart of trauma-focused therapy, that you get out of the narrative that you're stuck in. Sometimes I call it an immutable narrative that you're just stuck in, and you can kind of develop a different narrative. Maybe you see that when the trauma happened, you were so very young, and how could you have had the kind of expectations that you have of what you might do when you were so young and the aggressor was so big and so powerful. You come to see things in a very different way. So you shouldn't be afraid of the negative memories, because the more you can bring them up and work with them, the more opportunity you have to be able to give yourself a different way to look at them.
Fantastic. Thank you for that. There's lots of questions coming through now. Here's an interesting comment. In intergenerational trauma, maybe we are forgiving our ancestors of memories they found too much, too triggering, especially girls forgive grandmothers in this way, perhaps. Is there any research about gender bias in intergenerational trauma experience?
Well, you're calling it, these are really good questions. I wouldn't call it gender bias, but we've spent quite a lot of time looking at sex differences. In other words, if your mother was exposed versus your father is exposed, that might have different effects. If your mother had PTSD versus your father having PTSD, that might have different effects. If your mother was a child when she was exposed, that might also have different effects. And the effects might be different in male versus female offspring. Now, at first, that might seem crazy, like take the Holocaust. How can an event like the Holocaust affect a mother differently than affect an offspring differently if their mother was in the Holocaust versus their father was in the Holocaust? But that's where we get into the whole science of intergenerational trauma, when we start to think about all the ways in which effects of trauma can possibly be transmitted. And we can then easily come to realize that mothers and fathers have different mechanisms of passing things on. We can assert that both mothers and fathers can potentially pass effects on to the offspring through their parental behavior. But in mothers, there is the opportunity to have effects passed in utero that doesn't exist in fathers. And for mothers, if we're talking about transmission to offspring through sex cells, well, oocytes or eggs are really present at birth in females, and sperm is made throughout reproductive life in males. So when we're talking about the idea of that kind of potential transmission, which hasn't been demonstrated in humans, but has been demonstrated in animals, we're talking about a lot of different mechanisms of transmission that could be very different depending on whether a mother or a father was exposed. So it's not so much that it's a gender bias, but there's absolutely a different experience that might be happening to a male or female offspring, depending on whether the parent that is traumatized is a male or a female or both.
Thank you for that. I mean, there's questions here too, and I mean, like we we often get questions like these. The question is, do people have to go off the antidepressants before they undertake this therapy? And of course, we have on our website a drug interactions chart anyway that has been done by a spirit pharmacist, which shows the amount of time that people need to have gone off different medications. But I don't know the case. Actually, you will know for sure, Rachel, but with your MDMA trials, do the patients have to go off other pharmacological medications before the treatment?
Yes, for our trials, we're not going to study people who are taking antidepressants.
Yeah.
Serotonergic antidepressants are particularly of concern because MDMA also affects serotonin and causes quite a gush in serotonin release. So yeah, I mean, part of why you really do want to discourage using psychedelics on one's own is because of drug interactions and all sorts of other things. The responsible use of psychedelics as a treatment does require a medical clearance process because things can go wrong. And this is it's really important to emphasize that the reason that most medicines are prescribed by a prescriber is presumably that person has a lot of information and education and can really think through the complex issues that are involved in that. So again, that's a really good question. And you always have to keep that in mind.
No, it's critical. I mean, of course, unfortunately, around the world now today, there's so many people who are desperate for treatment and who want to get better. And, that's why it's important that we all work together to make sure that these medicines become available as soon as possible in medically controlled environments where patients are screened properly.
Right. And then, but on the other hand, one of the really challenging aspects of thinking about how to implement psychedelic psychotherapy in the future is not to have too medicalized an environment. And
Absolutely.
We talk about set and setting a lot when we talk about psychedelic psychotherapy. Set refers to the intention that you have when you're taking a psychedelic, let's say therapeutic versus recreational. But setting refers to where you are, who you're with, how does it look, can you commune with nature, are there beautiful things? And again, the average medical environment is probably not the best place to have a psychedelic journey. And that's going to be really challenging. What does the right environment look like to do responsible psychedelic psychotherapy where you're really making sure that you're dealing with all the important medical needs as well as providing an experience in the right setting? So we're going to have to do some real thinking about what does that look, what does that kind of a clinic, or maybe it's not even called a clinic, what does that kind of healing place look like? And so what I find really exciting about psychedelic assisted psychotherapy is the potential to really rethink how mental health care is conceptualized and delivered. And so that is one of the things that I'm really looking forward to in doing this kind of research.
That'd be fascinating. We'd love you to keep sharing all that with us. Lots more questions here. I'll just we'll try and answer them quite quickly now because there's so many. What about abuse suffered as an infant? Are these memories accessible? I guess that varies, right?
Well, they're probably not available as semantic memories. And, Bessel van der Kolk talks about, the body keeps the score. He talks about really how memories can exist, not necessarily as word memories, but in the body. So to an infant who doesn't have language, they're not being processed as, oh, this happened to me in words, but something is experienced in the body. And so that's the other potential benefit of processing a traumatic memory in an altered state of consciousness. It may not really, need to involve words so much. A lot of times people call these experiences ineffable, sorry, and they defy words. So I think that almost every trauma expert believes that an infant who suffered a trauma, there's some lingering memory, but it just might not be accessible in the form of words.
No, that makes sense. And here's another one actually along these lines. Intergenerational trauma, where does attachment fit into the picture? In particular, how does adoption affect the baby's brain? I've read that very young babies who are adopted experience lasting changes to their blood chemistry. How could psychedelic therapies assist the adopted adult to assimilate their early and traumatic experiences?
Yeah, that's a great question too. So early attachment is a really important way that parents, mothers transmit things to their child. When a parent or a mother has PTSD, attachments are disrupted. And this is one thing that can really affect the child. They're just dysregulated because the mother may over attach it sometimes and under attach it other times. And you hear this a lot in stories of the adult children of Holocaust survivors. They feel it's that their parents, their mothers, were sometimes completely overbearingly present and sometimes very absent. For children that were adopted, one could imagine that they were left and neglected and did not have secure objects or didn't have consistent attachments either. If they were adopted or cared for by someone that did show them the kind of love afterwards, hopefully some of that can be made up. But yeah, I think that to the extent that there are feelings of abandonment or lack of attachment or insecure attachments, and these are all really legitimate things for someone to work on. And it's hard for someone who's adopted to sometimes talk about that with their adopted parents, because the adopted parents may have come in late in the game and really feel like they're part of the solution and want to see in their adopted child that their presence has made everything better. Sometimes it's not easy to talk about the fact that there's still a sense of hollowness, or there's still a sense of longing for something that is lacking, that should have been there, and you can't really articulate it because you don't even understand what it's supposed to be. So yes, I mean, it is really valuable to be able to go deep into an altered state of consciousness to kind of retrieve what some of those feelings might be. That might be a wonderful thing for somebody to do. Might end up being a wonderful indication of psychedelics in the future. We might learn that in empirical studies.
Now that could be a really interesting piece of research, I think, too, that one. Look, just a quick one here and a couple more, and then because we're running out of time. I haven't seen this one before and I'm not aware of it, but I'll ask it anyway. I understand MDMA can have very serious, even deadly consequences for women depending on their estrogen levels. Is this taken into account with this form of therapy?
Yeah, so I don't know that. I haven't heard that and I don't know that. But what I really like about the question is that there's so much that we don't know that we have to learn. And it's really okay to raise these things. And I think that what we don't want is to have a situation that's binary. Oh, I love psychedelics. Oh, I fear psychedelics. We want to really be able to have a nuanced understanding of the fact that perhaps psychedelics aren't for everyone. And the kind of work that I've been doing for many, many years now involves trying to understand the effects that different drugs can have on gene expression networks. And this is very important work to do with psychedelics. It's very possible to learn a lot about psychedelics simply by creating cell models in a laboratory with human tissue, like your own cultured blood cells, and really look at the impact that different drugs can have on, let's say, estrogen gene expression pathways. I think that these are really good questions, and that we need as a scientific community to really take them seriously so that people will have complete confidence in the fact that these medications have been researched and that they can take them comfortably. So
Yeah.
thank you for asking that.
Thank you. I've got just two more quick questions before we have the last couple of slides. One of them is, what are some of the other potential barriers that might make it difficult for psychedelics to be adopted into mainstream psychiatry?
I think that we are still very affected by this message of, psychedelics being neurotoxic, bad for your serotonergic neurons. Um, Indeed, banning psychedelics in the late 60s and 70s and through the 80s, I think we're still suffering the lingering effects of that, even though it's been decades since that was true. And I think that that is a barrier. And, I sometimes recall a commercial that aired when I was growing up that showed an egg. Um, the commercial said, "This is your brain," and the egg was cracked into a sizzling frying pan. "This is your brain on drugs," right? And the message was, "Oh, don't do drugs. These drugs are going to have very, very bad adverse effects." And we're still suffering from that kind of spin and those kinds of messages. And even today, if you go on Google and you type in the word psychedelic drugs, the kind of definition that you'll find from like Oxford or Britannica or authoritative dictionaries will define psychedelic drugs as drugs that cause you to have hallucinations and delusions and no control over your perceptions. So we still think these drugs are dangerous in mainstream medicine, psychiatry, and most of the public. So we are going to have to work very hard to do the science that will provide the comfort level for people to adopt it, understanding that there has been just decades when society or the government or researchers or the scientific community has given an impression that these drugs are dangerous, and if you take them you will have substantial problems. So I think we have to overcome that.
Thank you. I know and am aware of the fact that you've done a lot of work in the field of veterans. And Brigadier General Sutton, the New York City Commissioner of Veterans Services, said, if this is something that could really save lives, we need to run and not walk toward it. We need to follow the data. Why do you think that there's been so much research to date done with these medicines for veterans in particular?
Well, I don't think it's been done for veterans in particular. I think veterans have signed up for it. I mean,
yeah.
So again, we have to put this in perspective. In terms of the MDMA trials, phase 2 trials enrolled like 100 or so participants altogether. This has just not been tried in hundreds and hundreds and hundreds of people in clinical trials. I think that combat veterans are more likely to take this kind of a risk. They have maybe they've gone to the VA and they haven't been happy with the level of treatment that they've gotten. Maybe they feel that it's a last resort, or I don't know why. I like the comment though that Dr. Sutton has made. I don't know if we should run. I think we have to walk quickly. I think what we have to do is do our due diligence. And again, we want to make sure that we understand how these drugs work in everybody who takes them, when they're indicated, when they're contraindicated, and it can be a game changer for veterans.
Absolutely.
Do this right. So I am particularly hopeful that this can really make a difference in the lives of veterans. And I think that it can, because I think this particularly helps people address experiences that do have kind of the good parts and the bad parts associated with them. So I think, yeah, I'm very, very hopeful. Very hopeful.
No, it's so exciting hearing, the work and your passion in this space. And, we get a lot of, I think I've told you, and you empathize with the fact that we probably get, every day multiple letters and emails and text messages and calls from people who are desperate for these treatments, and particularly a lot of veterans, who've actually tried so many different treatments. Like, you look at some of the case histories and you just think, wow. So that leaves me with my last question is, what's for you, Rachel, what's the mark that you want to make in this field? Like, what's the ultimate for you over this next, say, 1 to 5 years sort of thing?
Well, look, I am very, very invested in seeing this treatment broadly available to our veterans. I think that I have spent an awful lot of my career focused on how to make it better for veterans. And that's something that I really, really want to see happen, because so many of our veterans just feel that they have no choice but to live a life of disability. And I don't think that that's a true narrative. But I've also spent a lot of my time dealing with intergenerational trauma and racial trauma. And I think that it would be very important to understand whether these medicines can be used for those kinds of issues as well. So, yeah, I think that that's what I'd like to see. I think that I've been in the field long enough that I've also met a lot of people who have recovered from trauma and who have moved on to show post-traumatic growth and really make such meaningful lives, not despite their suffering, but almost because of it. And so this could really, given that trauma is not going away and so many of us seem to experience it, I mean, this might really help us not be so afraid of trauma, because we can understand that there is a way to make space for trauma and then use our adversity to kind of help others create better and more meaningful lives. And, if we can do that, then that would be a really important thing to spend time thinking about.
No, thank you. Thank you very much. It's really important, and there's some questions also on the chat about sexual abuse. And of course, these medicines are starting to be used extensively for survivors of sexual abuse. And should keep an eye on our webinars, because we will be offering more content in that space as well. So we'll just show just a couple more slides just before we thank Dr. Yehuda finally. Ilan, if you can just put on just the last couple of slides, that'd be fantastic. So this is our psych support services service led by Dr. Alana Roy, a psychologist with psychologists and therapists all over Australia. So if you are using these medicines, not that we advocate you do, but if you do and you need some support for integration, we do offer that service. And in general, if you just want more guidance, this is a wonderful service, and we encourage you to approach us and organise a consultation. There's also group sessions and so on. And next slide, thank you. So this is Tim Ferriss's wonderful quote about why he's donating so strongly in this field, because he sees it as a massive opportunity to affect millions of lives. And my husband and I, as philanthropists, also feel that way. It's not often you get a chance to really shift a paradigm. And we really encourage you all to give whatever you can to help support this movement, because we can't do it on our own. And it's up to each and every one of us collectively to improve the options available. Next slide. So how can you help? Start conversations, volunteer, join our chapters, read our wonderful educational content on our website, all our videos and webinars. Speak to your doctors and medical professionals because, as Rachel and many other of our presenters have reiterated, a lot of doctors and medical professionals still don't really understand these treatments. They don't understand how prospective they are, and there's still some stigma there remaining. So doctor by doctor, politician by politician, we need to talk to people and get them up the curve with these medicines. If you're in an area where we don't have a chapter, then by all means reach out and we can help you start a chapter in your area. And please do donate, attend our events. We've got some more wonderful webinars. And the next slide, Ilan. So that's a certificate in psychedelic-assisted therapy. So if you're on the call, you're a therapist or non therapist who want to learn these skills, this is a wonderful course. And we have some of the world's leading teachers involved, and Rachel will be lovely to talk to you about potentially if you're interested in teaching the session. We'd be very grateful. And then the next slide is our International Summit on Psychedelic-Assisted Therapies next November. These are a number of the confirmed speakers already, but we'd love to, we are actually expanding that. We've confirmed a couple more speakers, and actually Dr. Eli Kotler and Patrizia Slavuta, who spoke last week on trauma and addiction, will also be speaking. So we've got some great new speakers coming on board, and Rachel would love to talk to you about that as well. Next slide. Thank you, Ilan. So this is the rescheduling, and we hope to hear an interim decision in February. So please pray to all the gods of plant medicines and everything else, so whatever angels and guides you have, then please pray to them. And the next slide. So this is a trip of compassion screening in Adelaide next week. There's not a lot of seats left, so if you're from Adelaide, then please join and share this with others. And the next slide. This is the remaining webinars. Ilan, you need to just update that. That's a bit out of date now. So the final webinar this year is with Rick Doblin on the 25th of November. And we're also going to be screening in December the new documentary on Stan Groff called The Way of the Psychonaut, which I've seen and is wonderful. And we'll be having that as an online global screening in December. So yeah, so we'll just take that off now. Thank you, Ilan. So Rachel, I just want to thank you again for your superb contribution. We're really, we're so lucky to have people like you and others, supporting the work that we're doing here in Australia. And, we're a long way away from you, but in many ways we're all here together and we can do this together. So I just want to say thank you, and keep up your brilliant work, and do share any research with us or papers. We'll be very delighted to share them with our network. In fact, we usually send a thank you note out to everyone who's been on the webinar. So if there is an article or journal article or other article or video you want to share with us, please let us know and we'll put it on, we'll attach it.
Thank you.
Thanks so much, everyone. Thanks all.
Have a good evening.
Have a good day, evening, whatever you're up to. Take care. Bye.